Yeah, so it's a pleasure and an honor being with you all this evening. Dhaval asked me to talk about mechanical RV support in the setting of pulmonary embolism. And so that's something we obviously got a lot of experience during COVID, but also we've never had more tools to help manage these patients. Disclosures, I am a consultant for Abiomed. So just about 2 months ago in New Orleans, the new ACC AHA guidelines came out for pulmonary embolism management, right? And so this is taken directly from the publication Circulation. They're wanting everything to look like the chalk pyramid, right? They're just reinventing the wheel. But basically, it's a reanalysis of how we're going to be talking about how sick these pulmonary embolism patients are. And really starting with the ones at the level that they're going to be presenting in the hospital, we're talking about, generally speaking, the Class C patients who are going to be seeking help and trying to subdivide those patients based on whether or not they have evidence of RV dysfunction, clinical biomarkers, or respiratory modifications, and then moving on from D to E based on the level of hemodynamic compromise. We know that right heart failure impacts survival in patients with pulmonary embolism, and that having greater than 50% occlusion of the pulmonary artery tree is a strong predictor of having right ventricular dysfunction or right ventricular failure. Additionally, when it's identified, right ventricular dysfunction is associated with a 2 to 3, almost 4 times increase in mortality. And so because of the poor prognosis associated with right ventricular dysfunction, it is behoven on us to look for it and to be prepared to treat it in that context. When thinking about RV dysfunction in particular, the right ventricle is very different from the left ventricle. The shape is different, of course. It's preload dependent. But it doesn't adapt well at all to pressure and can fail quickly and can fail pretty dramatically when exposed to an unexpected new load. Additionally, the pulmonary vascular resistance is quite lower than the systemic resistance, and perfusion into the right ventricle differs dramatically from that in the left ventricle. In terms of etiologies of right ventricular dysfunction, QDMI is one that I encounter quite often, but heart failure, cardiogenic shock patients as well, progression of SCI. But for the talk this evening, we're going to be talking about pulmonary embolism in particular. In terms of assessing right ventricular dysfunction in patients for any reason, whether they are already identified to be in shock or whether they're simply at risk or you're considering why they're not doing well. We look at the clinical signs, of course, jugular venous distension, peripheral edema, bloating, elevated liver markers, especially the inflammatory markers like AST and ALT, but later on the bilirubin will rise and will stay high longer. Falls in urine output, obviously elevation in lactate, all of those would suggest clinically that we might be looking at RV dysfunction. Hemodynamic markers overlap a great deal with that of left ventricular dysfunction as well. So low systolic pressure can be from either, a low cardiac index could be from either, but going specifically for RV dysfunction, a high CVP, a low PAPI, all of those can contribute, and then we have the echo markers as well. In terms of devices that we can use to manage patients with right ventricular failure, we have the Impella RP, a tandem RVAD, Protect Duo, and of course VA ECMO. In this new guideline document from AHA-ACC, the mechanical circulatory support recommendations are very heavily leaning towards VA ECMO. And a lot of that data came from a meta-analysis. And what's interesting about the meta-analysis is that several of the trials here are from 2015, 2017, 2019, 2020. The Impella RP was a humanitarian device exemption device from 2015 to 2017, and then went through a couple of iterations, and the RP Flex didn't come out until 2022. And there was an FDA letter in 2019 saying that physicians that were using the RP Flex or the Impella RP in 2019 were waiting too long to implant it and were allowing patients to remain in RV failure for too long. So a lot of the data that was used, even now in 2026 to set the guidelines, was relying on considerably older data that is not reflective of contemporary practice. Still, we know that early recognition of RV failure and implantation of right ventricular support within 24 hours of shock improves the outcomes. And here there's a number at the bottom in terms of the indications for the shock. So ACS, acute on chronic heart failure, complex PCI, but including 5 pulmonary embolism patients in this trial. And waiting greater than 24 hours is associated with a considerably greater in-hospital mortality for these patients. So when looking at the Impella RP Flex, it's designed to lower CVP, to lower congestion, to improve cardiac output, cardiac index, and cardiac power output, and to deliver more blood to the pulmonary arteries. It can be placed from the IJ or from the femoral approach. There are some centers and places where it's been placed subclavian as well. And the immediate hemodynamic benefits include an improvement in cardiac index immediately, improvement in central venous pressure, and those improvements persist even after explantation and weaning. Additionally, a big push, and this has been an item in discussion in cardiogenic shock in general, is using invasive management on an ongoing basis. So placing a swan and leaving it there after the placement of right ventricular support to allow for guidance in the therapy for those patients. And so we look at those parameters, especially the PAPI, the stroke work index, to ensure that the patients are in fact recovering. And we want to keep tracking those values, including urine output, lactate, ALT, AST, bilirubin, all of those should be improving once the patient's on adequate support. From a practical approach, these are sort of the high-level numbers. Cardiac index less than 2.2, suggesting or being indicative of shock. A low PAPI, high CVP, all of those would suggest it, as well as the echo parameters. So going right for patient case. So this is a pulmonary embolism with RV failure that patient required and ended up requiring an Impella RP. So 75-year-old gentleman, out of hospital arrest, bystander CPR with ROSC. This was actually his grandson, adult grandson, that did the bystander CPR. And he had a CTA in the ER that showed bilateral PE involving proximal segmental arteries with some RV strain. He was already on norepinephrine and vasopressin that was started by the ER. We did a right heart cath. PAPI was 0.7, cardiac index of 1.5, pretty high pressures, of course, certainly contributing to the acute failure. Went in with, this was an Inari 22 device. Had a lot of oligemia, especially in the right lower lobes, right middle lobes. Twitter X now is full of images just like this. Your rep will be happy to generate another one if you like. But it's not exactly where the clot was, but it looks good on the page. Post-thrombectomy, the patient remained on moderate doses of norepinephrine, vasopressin, and so we decided to proceed with RP Flex. So we dilated up to 23 French from 22, not a big change there. Selected the right middle lobe, you can go right middle, right lower, and then placed the RP Flex from the neck. So that's with my partner, Dr. Prince there. Advanced the device up across the tricuspid valve, pulmonic valve, and up into its final position, and then remove the wire. And so in the end, it looks a little bit, when you're placing it from the neck, like a horseshoe. Inlet, outlet are about at the same level. Outlet should be right at the bifurcation from the trunk. Inlet should be at the SVC-RA junction. And of course, we're leaving a swan in place to help monitor this gentleman. From the neck, especially even more so than from the groin, I like to use modified purse string approach, and I like Oethibon. I end up tearing a lot of silk. I'm sure the surgeons can have a lot of recommendations on how not to do that. But this is at modified purse string, so grabbing the bottom left, top right, bottom right, and then doing a so-called surgeon's knot. It's basically a double throw so that it'll continue to travel. And so that allows us to be able to advance that later on. That's what that looks like there, that double throw there at the neck. Subsequently exchanged out. There are other ways to manage the access site from the groin. You could do ProGlide as well. I wouldn't necessarily recommend that in the neck, but in the groin it would be reasonable to do a pre-closure if you like. And that's what that looks like here. So patient ended up doing quite well. We were able to start weaning pressors in the cath lab before we brought him up to the ICU. Strong advocate of using bedside monitors as well to try to actively trend the values that you're getting from that swan. Pressors were weaned. Echo at 48 hours showed recovery of the right ventricle with normal function. The flex was removed at the bedside with additional purse string sutures, and then he was subsequently discharged. His case was actually picked up by the Houston Chronicle, and so this is some pictures from that article, and ended up doing a little bit of rehab at home before getting back to life as usual. So final thoughts, the right ventricular failure often goes unrecognized. The right ventricle, a little bit to us in cardiology, is still like the dark side of the moon. We don't think about it as much. We think it doesn't happen as often. It's probably happening a lot more than we realize, and we really need to be looking for it. It's associated with increase in morbidity, increase in mortality, especially in pulmonary embolism. Early recognition can improve outcomes. And then patients in cardiogenic shock from any cause should have a PA catheter placed to help diagnose, monitor, and manage their recovery. And that's it.